Hello, everybody. We're just getting organized to start for the session on accelerating multi-sectoral HIV prevention among AGWYW. They'll explain what AGYW stands for, give you something to keep guessing about, and all the women of reproductive age through a continuum lens. We're just sorting out how they're going to do their PowerPoint presentations.
Good afternoon. Hello. Hi. All right, so let's do this just to get us in the right tone. When I say hi, you say hello. And when I say hello, you say hi. It's really easy. Hello. Hi. Great. Now I feel that there's a bit of energy in the room. Thank you so much, everyone, for being with us today. We are here at a session that speaks to accelerating multi-sectoral HIV prevention amongst adolescent girls and young women and older women of reproductive age through a continuum lens. We are really excited to have you here. My name is Olerato Kehope from Botswana, a Her Voice Fund country lead, and I'm really excited to be co-chairing this session with Miss Lydia Zikomo, who is the UNFPA Regional Director for East and Southern Africa. By just looking at the panel, you see that we really embrace the intentional intergenerational vibes, and want to be able to learn from young women and older women as well. But also when looking at this panel today, you'll see that very unfortunately, but which is our reality, that the face of HIV in Africa is reflected in young women and older women as well. So we hope that you're able to really sink into what the presentation will be. We have really amazing leaders, health leaders, who will be speaking to us today. Very remarkable, who will be speaking to country contexts and lived experiences. And it's now my pleasure to invite my co-chair, Ms. Lydia Zikomo. A round of applause, please.
Thank you very much. As we begin and this panel discussion, Olorato talked to the fact that we are representing intergenerational perspectives in Africa, just by the way we've chosen myself and herself to be the co-chairs of this session. And I just wanted to highlight a little bit and set the scene for the speakers who are going to speak in much more detail to the situation we find ourselves with on this continent. So we've all heard the staggering statistics that in 2022, 63% of new infections that were recorded were amongst adolescents and young women on this continent. And that is a sad reality we are faced with, that just last year, so many young women and adolescents became HIV infected. And as we look at what that means in reality, by the end of this conference alone, there will be 3,100 new infections amongst young girls and adolescents. So it's a big issue for when we're looking at young people and young women particularly, and what we need to do around them. And in this region of Eastern Southern Africa specifically, where we're sitting today, there were ministerial commitments that were made on comprehensive sexuality and education, on sexual and reproductive health and rights for services for adolescents and young people. I wonder how many adolescents and young people are even aware that their ministers in Eastern Southern Africa made those commitments on their behalf. And therefore, there was a pledge by these ministers to roll out comprehensive sexuality education for adolescents and ensure that there were youth-friendly health services available for adolescents and young people. However, we know that the quality of these services, where they do exist, varies considerably. And not all young people and adolescents are still accessing what is in effect their right. Therefore, we have to keep pushing and doing more. On the other side of the spectrum, and I think it's particularly sad to me as fitting within this category, while there's been some progress on adolescent and youth programming, for older women of reproductive age, so looking at those between 25 and 49 years, we have stagnated. And in fact, it looks like we've neglected in the HIV and STI response focus, particularly on this age group, to look at what needs to be done to continue to register the right type of results and prevent new HIV infections amongst them. So a review of recent population-based studies reveal high incidence levels of HIV among older women, especially in the 25 to 34 years age group. And a review by my own regional office noted that a number of older women have an elevated risk of HIV infection, most of whom are still in their peak, as we know, reproductive age, especially in high HIV settings, prevalent settings. So we also need to take care of older women who are still of reproductive age as we focus on adolescents and young women. So we hope that the panelists will take us through what's coming out from the data, the evidence, and speak to us from both sides of the spectrum, because we can't afford to take our eyes off either side of the spectrum to prevent HIV continuing to have a female face. So without further ado, and we'll speak more at the end, let us turn over to the panelists who are going to be presenting. So back to you, Olorato.
Great, a round of applause, please. So our first panelist, I'm going to ask you both to come up just so that we have an appreciation of who will be speaking to us today. But our first panelist is Dr. Celestine Mugambi. Pardon? Please. And she's the head of Technical Support Division as the National Syndemic Disease Control Council, formerly NAC, and she's a technical lead for HIV prevention, adolescents and young people engagement, public sector capacity building in the HIV response, and coordination of development and implementing partners. She has over 15 years of experience in government policy and program development, so we know we have the right person in the room. Let's give another round of applause, please. Our second panelist is Dr. Rose Miranda. Please may you join us up here as well. Dr. Rose is a community health and interprofessional healthcare leadership specialist, currently serving as the director for the National HIV, Viral Hepatitis, and STI program in the Ministry of Health in Malawi. She has extensive experience developing health policy, strategy, and technical guidance for community health, HIV prevention, care and treatment, sexual and reproductive health, and maternal health, and design and implementation of health systems and health services. A round of applause for Dr. Rose, please. Dr. Celestine, the floor is yours.
Good afternoon. Good afternoon. Olerato, do I fall in the category of mature woman or young woman when you were speaking? I don't know. So I know how to engage in this. Be careful how you answer. So good afternoon, everybody again. My name is Celestine. I will take you through a very brief presentation from Kenya, lessons that we are learning as we program for adolescents and young people. And let me start by giving a disclaimer. As a national government, for us, we recognize adolescents and young people as a priority population. I know the session is on adolescent girls and young women, but I'm going to be presenting from the lens of AYP, of course, but touching on the girls and the young women. So next slide, please. Is it moving? All right. So this is the background of how we do programming and policy. I think if there's one thing in Kenya we are good at is coming up with policies, frameworks, and guidelines. And if you look at all those documents I have projected there from the NAC and also from the Ministry of Health and other sectors, adolescents and young people are a priority population. So they are well embedded in the strategic framework that is going up to 2025 as a priority population. Next slide, please. So this is our HIV burden. I'm not going to dwell too much on this one, but just to say that we have seen remarkable decrease in new HIV infections over the last couple of years, about 78%. But if you look at our epidemic in terms of prevalence, it is largely a feminized epidemic with variations across different populations like the KP, AGYW, but also with variation across different counties. That is where we are with AIDS-related deaths. We're still not happy with that, but it has come down a long way, but we're making efforts to ensure that we do reduce that. Next slide, please. So the next slide is coming up is around incidence and new HIV infections. So as of 2023, we had 22,154 new HIV infections from 0 to 100. About 7,000 of these were in adolescents and young people, 15 to 24. And about 41% of those 7,000 were in there's 15 to 24. And then of the 7,000, almost 2/3 were in adolescent girls and young women. So they're still a priority for us. Next slide. I wanted to show this slide. I know we are talking about 10 to 24, but in keeping with the theme of this session about a continuum of care, we looked at our data. And for us, what is alarming is that adolescents and young adults aged 15 to 34 actually are giving us 75% of all new HIV infections. Usually we focus from 15 to 19, 20 to 24, and then we stop there. But if you look at the 25 to 29 and 30 to 34, we do have a very big problem also, more in the females, but in the males. So even us, as we adjust our programming, we're starting to look at that age band that is categorized as general population. Next slide. So the next slide is about boys. I know this is a session for girls, but I cannot not talk about my boys. Now, if you look at the contribution of boys and young men, who are the sexual partners of the girls that we are programming for, 72% of all infections 15 plus are coming from the ages of 15 to 34. but those are the sexual partners of the girls that we program for. So I wanted to emphasize that even as we do AGYW programming, we have to look at the boys and men as a priority population. Next slide. So for us, we've acknowledged that new HIV infections are playing a significant role in the changing epidemic typology. And we have done an epidemic appraisal, and we have got 47 counties in Kenya and one national government, so 48 governments, so to speak. But each county has been prioritized and has been clustered based on the epidemic appraisal as either concentrated, generalizing, or mixed epidemic. Now, out of the 47, 25 counties really have got to focus on adolescents and young people. That is the generalizing and the mix. So as I speak, each county is looking at their data and adjusting their county plans to accommodate the findings of the epidemic appraisal. Next. Now, when we talk about vulnerabilities of adolescents and young people, we have a lot of data back home, so we looked at it. Now, when you look at sexual debut, this is sex before the age of 15, 19% of men said they'd had sex before the age of 15, and 8% of women as of our KDHS 2022. Now, why I put this is that in our last KDHS, it was the reverse. The girls who reported that they had had sex by the age of 15 were more than the men. But we're actually seeing a shift in the epidemic. So speaking again to programming, I think low knowledge is an issue that cuts not just across Kenya, but sub-Saharan Africa, where 54% of females and 55% males. So again, the males are beginning to creep up here with low knowledge on HIV prevention. We looked at access to health services, and this is where we wanted to find out, do the young people feel that what we call adolescent-friendly services are available to them and easily accessible? And this is data from a survey that we carried out in July this year. So 54% of the females versus 45% of the males found it reachable. So again, we're able to reach more girls, but again, the boys are lagging behind. But I wanted to highlight the data, when we looked at programmatic data, between July and September 2023, if you look at all those who tested above the age of 10, 71% were females. But we saw a higher positivity rate of 1.8% versus 1.3% in the males. So we've got 29% of the men coming for testing above 10, but we have a higher positivity rate in this age group. And even as we think about access, when we did the survey, one of the things young people told us is that we talk about the services could be there, but how do I reach? I don't have money for transport. I have to leave my day job to go and queue there at the clinic. A lot of them don't have social health insurance or health cover. So how do they actually access those services? And when we talk about free services, are our services at the facilities actually free? Next slide. Again, we looked at teenage pregnancy by education level. I think this speaks to almost every country that the more you stay in school, the higher the risk of you getting pregnant. But also when we looked at our data, surprising enough, things are beginning to change. Performance of boys in school is suboptimal as we speak to girls in Kenya. And we actually have got less boys transitioning to secondary school. We talk about enrollment, retention, transition for girls, but we are beginning to see a shift. Next slide. Other vulnerabilities, we looked at SGBV data, and about 36% of all the reported cases in 2022 were between the ages of 10 to 17, and we are actually seeing an increase in that. And when you look at who the perpetrators are, I think the big blue ring that you're seeing, 68.6%, is the current husband or intimate partner in the context of the girls that we are talking about. Next slide. Again, we looked at our PEP data, and I think what is disheartening is that only 61% of cases actually were coming within 72 hours. So we are losing a huge chunk of adolescent girls and young women reporting. And even if you look at the seroconversion rate, when you have 110 young women seroconverting, then that actually is something that we need to critically address. Next slide. Now, for us, we look at multi-sector data, and I wanted to highlight this slide on alcohol and substance abuse and the contribution to the criminal acts. So we looked at data from, should I call them prisons, correctional services, okay? And we looked at data from the agency that talks about alcohol and drugs. And I wanted to point out, if you look at the bars above, if you look at the incarceration rates of males in blue versus females, we have got a lot more men in prisons, and especially young men. There's a legend there that says crimes against morality. However you want to interpret that, interpret it. But these crimes against morality. Okay, so when you interview the young men, some will tell you, I'm 16, I had sex with a 14-year-old girl, but I'm in a Boston correctional facility. So we rescue the girl, but we incarcerate the young man. So by the time he gets out, he's actually a hardened criminal. But if you look at the reasons why we have got these crime rates, it is, again, unemployment, alcohol and drug use, idleness and poverty. The same vulnerabilities that are making our young people at risk of getting new HIV infections. Next slide. So for us, we are looking at addressing intertwined challenges, new HIV infections, gender-based violence, and teenage pregnancies. Next slide. So some of the lessons and opportunities that we have seen even as we program for this cohort is building and embedding a multi-sector response. So really having the different sectors coming on board, but actually having the adolescent and young person at the heart of the response. So for us, what is our slogan right now is a whole government and a whole community approach. Next slide. So we're changing also how we're doing our response. Money follows the epidemic. So where you have got high HIV incidence, high prevalence is where you go. But when we look at the other indicators of teenage pregnancies and SGBV, we've actually purposed to work with counties with high rates of that, even if the HIV incidence is low. So for us, nobody is being left behind, and a lot of work has gone in support from national and county governments to work with counties. We've got counties like Samburu, which has got very low HIV incidence, but the teenage pregnancy rates actually are astronomical. And that being a proxy indicator for new HIV infections, we cannot afford to leave them behind. So even how we're changing our programming, money is not necessarily following the HIV incidence, yeah, like it historically has done. Next slide. Next one is on coordination. And coordination, I've put it in two parts. I think the first one is coordination of partners and stakeholders. And here I mean development, implementing partners, but other ministries, departments, and agencies. So the way we are structured, we have a national multi-sector working group that provides enabling environment for the AYP program. But at the sub-national level, each of the 47 counties also has a similar technical working group made up of different sectors and also the communities, but most important, the young people are actually represented. Each of the counties actually has developed a plan for adolescents and young people, either separately or integrated into the county development plans. So they're looking at data, not just on HIV, but on SGBV. The other one is coordination of data. And for the longest time, we were looking at HIV data, incidence, prevalence, treatment coverage, tested on treatment, rarely suppressed. But when you begin to overlay the different data sets that we get, we actually begin to tell a particular story. So what we've done as the AYP program, we've actually developed a data visualization dashboard. This is not a reporting tool. This is a tool that mines data from existing M&E systems, not just in health, but outside health, and projects that. So at the national level, we are able to see this data per county, per year, even per quarter. And at the county level, they are able to do this. So as we speak, we have got data from Ministry of Health, Ministry of Education, the Child Protection Services, and we've also got partners coming on board because they do a lot of work in the community. So we also want to start having community data being projected here. And most important, we have got young people who are supported by partners to do work in the community. That data gets lost in translation. So we also want to be able to mine that so that we can actually see the comprehensive response at national and county level. Next slide. Now, the service package review, and sorry, my slides seem a bit off. So as we were talking about reaching this population, we've actually asked ourselves, so what package are we offering? Because we've talked about a comprehensive package for the longest time. And so what has happened back home is that now this package, a package of care, has been reviewed. We've updated the nutrition sections. We've also expanded and added components of mental health and GBV. We've updated the PLHIV section with the new ART guidelines. And I think also what we discussed as a group is the issue of transition. Now, there's different types of transition. For us, when the children go to secondary school, we see a dip in viral suppression. So there's transition from primary to secondary school. There's transition into teenagehood. There's also transition from being in the pediatric clinic up to 18 into the adult clinic. Because what is happening once you turn 18, you're told, go to the adult clinic. These are still in our cohort. So how do we support them to navigate that transition? But most important, are the healthcare workers at the facilities empowered to support them to navigate that transition? Now, the transition is multisectoral. If you're talking about children taking drugs in school, you have to engage the Ministry of Education. And a lot of work has gone into that. We have trained teachers, you name it, everybody. But I think we cracked it sometime this year and last year when we actually got a hold of the matrons. Now, the matron in boarding schools is the one who actually dispenses the medication to the children living with HIV in school. All the matrons we met told us they had never undergone a HIV training. They didn't even know what ARVs are. So when you talk about dispensing, they had no idea. They had no idea about the importance even of privacy to safeguard against stigma and discrimination, and even how to give the medication. So for us, we'll continue to work with the Ministry of Education to aid in those transitions. We've also added a component of adolescents, and he said, my time is up. 2 more minutes. Adolescents and the law. Because we're in conflict. We have the Children Protection Act that says you're an adult when you're 18, but we also have got guidelines that say once you're 15, you can go for a HIV test. So I can test you for HIV, but if I'm to give you ARVs, your mommy or your daddy has to be in the clinic. So there's also that, and how to safeguard the workers. All right. The other one, next slide, is around peer-to-peer. We've realized the importance of this. For us, we're working with different youth groups, but I think as an agency, there's a group that we work with at national and county level. So these young people have been identified by the counties. We have capacity build them, and they're actually able to engage their peers on an ongoing basis, of course, with support. So they will need to be supported. Next slide. And this is my last slide. We have had to rethink how we do our programming by employing the human-centered design, even as we think about the continuum of care. So when you have a young person in front of you, you have to think about pubertal maturation, okay? Then you have to think about menstrual hygiene. We're very happy to dish out sanitary towels, but there's something else we don't consider, which came up in a survey a couple of years ago, dysmenorrhea, painful periods. So the girl has pads, but she's at home because of painful periods. You must also think about her sexual reproductive health for her and for the young man also. So teenage pregnancy, there are those of young people in Kenya who really are abstaining. So can we support them to do that, okay? Early pregnancy detection, can we get them into ANC and postnatal care? And once they've had their babies, then how do they get integrated back into the community and to the schools? You have to look at mental health, which now we're looking at. Like I told you, we've integrated into our service package, and then we prepare them for transition, most important transitions into adulthood. And as I close, I would like to, next slide, just to acknowledge my colleagues who have supported me with this presentation. It's not my work, it's a whole country work, so everybody has to be acknowledged. But I wanted to say this as I close. I think we have done the AGYW a big disservice by not engaging ABYM. These girls don't live in isolation. They live with the boys. There's a group of young men who told me, it's okay, doc, program for your girls, but when they leave, they will find me here waiting for them. So it's time. So the boys and young men have to be on the table. Thank you very much. And sorry for, yeah.
Dr. Celestine has given us such a comprehensive presentation in just about 14 minutes. So another round of applause for her as well. She's just given us the highlights of the multi-sectoral packages available for AYP, Adolescents and Young People Programming, and we zoomed in a little bit on adolescent girls and young women. I will now invite Dr. Rose to give us the other side. We're flipping the coin now. When we're looking at emerging trends in new HIV infection among older women of reproductive age. A round of applause for Dr. Rose, please.
Thank you very much. When we're seated here, we're constantly looking at the 10 minutes. And it makes the presenter anxious. My presentation is going to be short, but it is biomedical biased. I think I just want everybody to be aware. I know that the discussion is about multisectoral, but Malawi was just supposed to showcase how we have adapted what we saw in our data in 2023, and how we continue to look at our data, what is coming up, and how we need to continue shifting our strategies. So it is biomedical focus, but that doesn't mean that we don't have interventions for GBV, comprehensive sexual education, and all the interventions that my colleague has shared. So it's about adapting the HIV response to a changing epidemic. I will not labor to share more insights about the AP info for Malawi. Just know that our HIV prevalence, according to Spectrum estimates, is at 7.7%. We have had a fast decline in HIV incidence from 2015, when we had our first fear, to 2020, from 0.4% to 0.2%. So what we do, Malawi is one of the countries that has got very strong data systems. We appreciate the PEPFAR investments that have contributed to the massive data that we are able to triangulate for our decision making. So we usually have data-driven reviews for our HIV response, and we have very strong biomedical data. And we have moved into precision prevention approaches into HIV prevention programming. And that has also been guided by cost-benefit analysis of the HIV interventions versus investment needs for scale-up. So we have been looking at what our data is telling us, what the priorities look like, what the financing package is available, and what is it that we can do with the financing package to have the maximum impact. So Malawi is just one of those low-income countries, and I shouldn't lie, we are donor dependent. We have been, we depend on Global Fund, we depend on PEPFAR and other partners, but we have moved into another gear whereby we have developed a healthy financing strategy, whereby we want to mobilize more domestic resources moving forward. That is what we have started now up to 2030 and beyond. And there's a lot in there, because it's now about medical insurances and everything. I just wanted to provide that clarity. So what we are doing now is looking at how best can we use the resources we have now to have the most impact, to invest in the most cost-effective but impactful interventions, issues of value for money. So that's what the second bullet is all about. But at the same time, we're also looking at reducing barriers and improving access to services, particularly for key populations and other priority groups. Pregnant and breastfeeding women and adolescents are also part of those very important groups. So in terms of reducing barriers, I see that the slides are not moving. I'm on slide number 2. Before that. So, and I was just talking about how we have been managing the response into areas of being data-driven for our decisions, but we have also adopted the precision prevention approach. We are looking at how we can reduce barriers to access for priority populations, issues of integrated service delivery, issues of options for key populations, introduction of new HIV technologies, but also considerations for male engagement, and ongoing tracking and monitoring of our data. So now I will take you to where we are. So our epidemic has been contracting since 2020. It was contracting, but the fastest decline, we have seen it from 2020. It's related to policies, I know, and probably interventions that we put in place. So we have seen fewer infections than deaths among people living with HIV. As I've mentioned, there's a decline of 0.6%, and this is the decline that we are going to see up to 2030. overall, 88% of people living with HIV are virally suppressed. And if you look at the proportions, we are already above the 95 target for this one. And the decline has been in all the districts. But when the analysis is done, it is also in parallel with ART coverage. And 12 districts have achieved epidemic control, but we're also seeing that untreated men are 3 times more likely to transmit than untreated women. So that's a message about how we need also to focus on men. So in terms of low and declining incidence among the general population, this pyramid is just showing what we have seen in 2023. We have been focusing on adolescent girls and young women, and I guess our investments have contributed to what we are seeing. But suddenly, the adolescent girls and young women, 15 to 19, there are fewer infections compared to the older age group. So 20 to 29, that's where now we are seeing more of the HYWs from 20 to 29. Probably the others, I don't know are we calling them young women? We need to find a name for them. So this is mature adolescents. So the mature adolescents now, that's where we are seeing the infections. And this is worrying because these are the people that we invested 5 years ago as HYWs. There's something wrong that is happening. Now, because our incidence is almost below 0.3, so the slide person is not helping me. Can we? Yes. So because our incidence has declined so much, according to the UNAIDS guidance, and if you use the adolescent girls and young women risk stratification tool, we are finding ourselves in a situation whereby it is very clear because that tool can be able to give you risk population sizes by age, but also incidence rates by risk behaviors, but also annual new HIV infections by risk behavior. What we saw on the pyramid is the spectrum estimates. And this is what you are seeing is when we use the UNAIDS HYW risk stratification tool. So it is showing us which age groups have no sex, have one regular partner, but also those that have non-regular partners. But also it is showing us the young women that are into sex work. So we did this analysis and we are able to determine which districts we need to focus because this is at subnational level, but also which age groups we need to focus. So we have 15 to 19 who are into KP, sex work. Then we have 20 to 29 who are into sex work, but we also have 20 to 29 who have multiple partners. Those are the high risk categories, but we also were able to look at the districts and we have figures like 100 in some districts, 200, small figures, but that is related to the overall decline in the HIV incidence that we have experienced. I also decided, can we have another slide, please? I also decided to pull out another set of data. We have started disaggregating our antenatal data because from the reproductive health, it's not disaggregated. So we have a robust tool for testing, and now it can give us data on by age bands. We were waiting for 1 year, but because this ICASA was happening now, I decided to have this data analyzed just from December 2022 to November 2023. So indeed, there is decline in new infections among those aged 15. And you can see the red, or call it orange, you can see the HIV positivity. So 15 is 0.5, 20, 1.2, and it is increasing as you reach even 35, which is, and even 40, this is very serious. But then what puzzled me when I was looking at this data last week is that we are seeing more pregnancies among the 15 to 19. We are also seeing pregnancies in the 20, because this is antenatal data. And I think even though it's just December to November, it is still reflective because our testing coverage is 98% for Malawi for antenatal women. So we have implemented DREAMS programs, we have implemented HY packages through Global Fund. So we have reduced the new infections among HYW, but they are becoming pregnant. We have a lot of work. This is really puzzling. So it is, we know that our fertility in Malawi is very high at the moment. The data that we have from the our facilities was even the NSO projections in terms of women that are delivering. It was low. It was lower compared to what we are seeing. I mean, what we are seeing in the clinics is more compared to the National Statistical Office projections. So for our spectrum, we used the world population projections. But even just from our data, this is what we are seeing. And this is, if you add those, we are talking of 470,000, this data just for 1 year. I mean, it's not even 1 year. So our total number in terms of women that are attending, that are delivering, which is about 680,000, I think is a true reflection. But this talks a lot. So in terms of strategic prevention programming in a changing epidemic, I mentioned that it's about precision prevention. So it's obvious that we have to make sure that every man is virally suppressed. We should get them wherever they are, test them and put them on treatment because they are the ones that are infecting all these up to 29. So ART viral suppression among men is a priority. With the gender power issues, we know that it's not a lot of women who propose the men, it is the men who propose us. We also have to we have to closely and act early on HIV drug resistance, but also we have to target almost 80 to 90% of PrEP. We should cover the female sex workers, the young women who are into KP work, and even the older women. Everybody who is at high risk we should have about 80, even 90% coverage. And demand creation is key, adherence is key, but also decentralizing services. The issue of integration of PrEP into SRH services and even including even cabotography within family planning, because not all women are going to come to are getting pregnant, but others are also, they find themselves in the family planning clinic only. And we have also learned that use of STI clinics is critical. Whether you are a KP, whether you are a pregnant woman, anybody would find themselves, if they have an STI, they will come to the facility or the private clinic, and that's where we need to focus our HIV prevention packages. Anybody who has an STI should not get out of whether it's a private facility or wherever without getting the whole package. And for us, we have about 430,000 people every year who register with STIs. That's a good population that we need to focus on prevention. But I should also talk about the condom. The condom is the cheapest condom to the last mile. It's a strategic initiative that some countries have worked with Global Fund. This is something that can also help us a lot. Now, we had to redefine our HYW package. It is HY plus package. We are still in the process of naming it, but we have now defined, based on our data, what we need to provide for those young adolescents that are into sex work, those that are not into sex work but are at risk, they are HIV negative, those that are 20 to 29, they're into sex work, 20 to 29, multiple partners and so on. So our package has everything from biomedical to non-biomedical services, but also including their partners. So this is what we are now advocating. We have included in the Global Fund application, but also we had